Pulmonary tuberculosis. Clinical picture of pulmonary TB: non-productive cough, dry cough for more than 2 weeks raises suspicion of TB, symptoms of progression, productive cough with purulent sputum, hemoptysis, that is blood in sputum, shortness of breath, pleuritic chest pain, low-grade fever, usually in evening with night sweats, weight loss, often severe, anorexia, decreased appetite, malaise, weakness. Any contact exposure history is important as it gives clue to diagnosing TB. Initial investigations in pulmonary TB are acid fast bacilli smear microscopy, nucleic acid amplification test, for example, GeneXpert, chest X-ray or CT chest, mycobacterial culture confirms the diagnosis of pulmonary TB. On acid-fast bacilli smear microscopy, mycobacteria stain pink. Disadvantages of acid-fast bacilli smear microscopy are: it cannot differentiate Mycobacterium tuberculosis from other non-tuberculous mycobacteria. It stains both viable and non-viable mycobacteria, thus organisms killed after treatment are also stained. Nucleic acid amplification test. Nucleic acid amplification test advantage is that it has low cross-reactivity with non-tuberculous mycobacteria. Limitation of nucleic acid amplification test is that it detects both viable and non-viable mycobacteria. Thus, it will detect non-viable mycobacteria which have been killed after treatment. Culture and sensitivity is the gold standard diagnostic test. It identifies mycobacteria species. It identifies drug-resistant mycobacteria strains. But limitation is that it takes 2 to 6 weeks for positive cultures to develop, 2 for liquid media and 6 weeks for solid media. Thus it delays the initiation of treatment. Imaging. Normal imaging does not rule out TB. Although radiographic changes are common in immunocompetent patients, individuals who are immunocompromised can have normal imaging findings. In fact, changes in lungs are hypersensitivity reaction. A heterogeneous, partially circumscribed consolidation is present in the left upper lobe. Same X-ray with overlay. A heterogeneous, partially circumscribed consolidation is present in the left upper lobe. Green overlay. A solitary lower lobe pulmonary nodule, black arrow, projects over the right anterior fifth and posterior eighth ribs on the chest radiograph. 1, 2, 3, 4, fifth anterior rib, 1, 2, 3, 4, fifth, sixth, seventh, eighth posterior rib. CT confirms that the nodule, white arrow, is a calcified Gone lesion. Gone lesion or focus is a tuberculous caseating granuloma. There is marked opacification of the middle and lower left hemithorax from pleural effusion. In the right hemithorax, a small meniscus from effusion is seen laterally. The cardiac silhouette is shifted slightly to the right and the left bronchial tree is slightly elevated. There is marked opacification of the middle and lower left hemithorax from pleural effusion. Menisci, white dashed lines, help confirm the presence of effusion extending to the mid-thorax. In the right hemithorax, a small meniscus from effusion is seen laterally, indicated by red line. Meniscus is a concavity. The cardiac silhouette is shifted slightly to the right, indicated by blue line and arrow, and the left bronchial tree is slightly elevated, indicated by black lines and arrow. Multiple parenchymal airspace opacities and cavitary lesions are seen in the upper zones of both lungs. Multiple parenchymal airspace opacities, examples indicated by green overlay, and cavitary lesions, examples indicated by C, are seen in the upper zones of both lungs. A thick-walled, irregularly shaped cavity in the left lung apex is surrounded by micronodular opacities which are better seen on the CT image than on the chest radiograph. A thick-walled cavity accompanied by consolidation or nodular opacities can signify active disease. A thick-walled, irregularly shaped cavity (green overlay) in the left lung apex is surrounded by micronodular opacities, examples indicated by dotted lines, which are better seen on the CT image than on the chest radiograph. A thick-walled cavity accompanied by consolidation or nodular opacities can signify active disease. Bilateral heterogeneous consolidations show an upper lobe predominant distribution. There are scattered small airspace nodules and cavities are present within areas of confluent opacification. The leftward tracheal deviation confirms the presence of left upper lobe volume loss. The left costophrenic angle blunting could represent pleural thickening or a small effusion. Bilateral heterogeneous consolidations (green overlay) show an upper lobe predominant distribution. There are scattered small airspace nodules, examples indicated by yellow overlay, and cavities (red overlay) are present within areas of confluent opacification. The leftward tracheal deviation, indicated by black arrow and dashed outline, confirms the presence of left upper lobe volume loss. The left costophrenic angle blunting, indicated by the white dashed line, could represent pleural thickening or a small effusion. A cavitary lesion containing gas is seen in the medial left upper lobe. Additional airspace opacities and parenchymal micronodular opacities are also present. Cavities may contain air or air fluid levels. Dense opacities surrounded by discrete micronodules can be seen in both tuberculosis and sarcoidosis. These have been termed the Gleason sign. A cavitary lesion containing gas (green overlay) is seen in the medial left upper lobe. Additional airspace opacities, black arrows, and parenchymal micronodules (white arrows) are also present. Cavities may contain air or air fluid levels. Dense opacities surrounded by discrete micronodules can be seen in both tuberculosis and sarcoidosis. These have been termed the Gleason sign. G is gas, T is trachea, this is esophagus. Numerous solid and ground glass centrilobular nodular opacities are present. Denser ones are solid nodular opacities, while dimmer ones are ground glass nodular opacities. Some opacities have coalesced into regions of consolidation. Multiple dilated and thick-walled bronchi with areas of bronchial impaction are also seen. An enlarged, elongated lymph node is visible in the left mediastinum and a very small left pleural effusion is present. Numerous solid examples indicated by red arrows and ground glass examples indicated by green arrowheads, centrilobular nodular opacities are present. Some opacities have coalesced into regions of consolidation, example indicated by green overlay. Multiple dilated and thick-walled bronchi, examples indicated by red overlay with areas of bronchial impaction are also seen. An elongated, enlarged node, yellow overlay is visible in the left mediastinum and a very small left pleural effusion, blue overlay is present. Clusters of small centrilobular nodules are seen in the periphery of both lungs. Some nodules are located at the distal ends of branching opacities. This appearance has been termed the tree in bud sign. The tree in bud sign was initially reported in Mycobacterium tuberculosis infection. A benign granuloma in the right lung is almost completely calcified. As culture results take few weeks, so patient may deteriorate during that time. So treatment is initiated based on clinical picture plus positive nucleic acid amplification test or clinical picture plus positive radiological signs. RIPE TB regimen. RIPE TB regimen consists of rifampin, isoniazid, pyrazinamide, and ethambutol. RIPE TB regimen has two phases, intensive phase and continuation phase. Intensive phase consists of 8 weeks. The dose of rifampin is 10 mg per kg per oral once daily, typically 600 mg per oral. The dose of isoniazid is 5 mg per kg per oral once daily, typically 300 mg per oral. The dose of pyrazinamide is 25 mg per kg per oral once daily, 1000 mg per oral once daily if ideal body weight 40 to 50 kg, 1500 mg per oral once daily if ideal body weight 56 to 75 kg, 2000 mg per oral once daily if ideal body weight 76 to 90 kg. Ethambutol. The dose of ethambutol is 20 to 25 mg per kg per oral once daily, 800 mg per oral once daily if ideal body weight 40 to 55 kg, 1200 mg per oral once daily if ideal body weight 56 to 75 kg, 1600 mg per oral once daily if ideal body weight 76 to 90 kg. Continuation phase. Continuation phase consists of 18 weeks. It contains rifampin and isoniazid. Rifampin 10 mg per kg per oral once daily, typically 600 mg per oral. Isoniazid 5 mg per kg per oral once daily, typically 300 mg per oral. Adjuvant treatment. Pyridoxine to prevent vitamin B6 deficiency resulting from isoniazid for all individuals at risk of neuropathy. Pyridoxine 25 to 50 mg per oral daily. RIPE TB regimen consists of first 2 months of rifampin, isoniazid, pyrazinamide, and ethambutol, and next 4 months of rifampin and isoniazid only. Restart full treatment if there is an interruption of 14 or more than 14 days during the intensive phase.